I've seen folks that do colpotomy for tissue extraction for like myomectomies, right? Patients who are going to get pregnant, patients who are at least planning on getting pregnant, who are wanting to get smaller abdominal incisions. So for robotic or laparoscopic myomectomies, don't want to make that big incision, but you don't have a colpotomy or vaginal colpotomy from a hysterectomy, but they're making a posterior colpotomy incision. And it seems like it works pretty well. How are you closing those? Are you just doing a barb suture single layer? Are you doing it in 2 layers? How do you close those?
Single layer to ovacral I use, but probably whichever suture is probably not that relevant there. But we do single layer. I try and approximate peritoneum and vaginal mucosa together, because it's always it's that dissection space between the peritoneum and the mucosa is where your oozing is and where your risk for hematomas is. And if you can compress those 2 layers together, then, but I think whether you do that in a running suture or in separate figure of 8s, it probably doesn't matter. I think it's very forgiving there.
I feel like I could ask another 100 questions about this. I know you're a busy surgeon and we're grateful you spent time. Any last thoughts for our listeners on vNOTES, on things that they should think about when introducing this into their surgical practices?
Yeah, I think go through the proper training pathways. They're available, and they're available all over the world. I think you have listeners all over the world, but these courses are being given in the same way everywhere. What worries me most is people watching a YouTube video and thinking, okay, I can do this. And it's not difficult surgery, but as with any technique, there's just lots of little tips and tricks, and surgery is always in the detail. And if somebody explains you all those details, it will just be so much safer for your introduction. And then a second thing, I think once you get started, is to start with the very, very easy cases. If you start with very easy cases, then you can gradually build it up. It will just be nicer. It will be safer for your patient. It'll be nicer for your whole team, because it's a new procedure, not just for yourself, but for your whole OR team, and you have to get them involved in the process. You have your scrub nurses and your anesthesiologist, and you have to get everyone involved in the process. And if you can then make sure that your first cases go smooth, you keep everybody motivated, and it's a safe and easy implementation. I think the problems we see is people who try to run before they can walk, and they start with a 800-gram uterus. That's not the way to start a new technique.
I think that's not different than what we see with our colleagues, whether they're trying to start laparoscopic surgery or jumping in, doing 2 to 3 hysterectomies a year and think, oh, we'll go ahead and just do this 1 kilo case. It's like, make sure I'm around for that one, because I think like anything with surgery, it is repetition. It's everything, minimize variability. It is getting as many of these as you can, so you can start to see the subtle differences and nuances with anything. But yeah, it sounds like, though it's a new approach, old adages are true, and it's all about, developing techniques. Start easy and work your way up, and give yourself the space and patience and your whole team the time and energy. But starting with that training, I can say from personal experience, having done the training, it's done really well. I mean, it definitely was important for us to do that. And as we start doing them where we are now, I think the reason we're going to have good outcomes is because of the training and because of the team that we've built, and the number of surgeons who are committed to helping all of us get better. Actually, one last question. I just thought of this as we're wrapping up. Robotic surgery, single site, anything. Is there any examples that you've used the robot with this stuff, that you're using any additional besides straight stick laparoscopy? I assume that's traditionally what you've done. Is that something that's being done, that's being talked about, using vNOTES in combination with robotic surgery?
Yes, yeah. There's a whole big topic. I think we can do a whole podcast session about that, but I'll keep it brief.
We'll have you back.
It's inviting myself. It's what I'm doing now. With the current existing systems, I tried a couple of years ago and looked with a Da Vinci Xi whether we could do vNOTES, and we did 30 or 40 cases. And it works. It's just there's no benefit. It's making life difficult. It's not made for it, and there's no space for the forearms. You can do it with 3, but there's a lot of arm collision. It just adds a lot of extra time to the patient and no, to the surgery, and no benefit. So I think there no, but I think there's a lot of development in robotics, and there's a lot of new systems coming. Single site system, you have the SP system from Intuitive. I work a bit with Momentous. They're developing a robot for transvaginal use specifically for vNOTES, and they're on the market. I'm in Europe. It's not on the market here, but it is on the market in the US.
Is that the one that goes behind the uterus and looks up laparoscopically?
And retroflexes.
Yeah. I've seen that.
So again, I think we're going to need studies. We're going to need evidence, and it's going to be hard. vNOTES endoscopically is not that difficult, and our procedure times are getting so short compared to laparoscopy that to prove a robotic benefit to that is gonna take time. But I think it's going to be the same as with robotics transabdominally. We also don't have a lot of evidence yet, but there is a group of surgeons that feels more comfortable doing it that way. And then that's absolutely great because that's better for the patient. And there'll be a group of surgeons that feels more confident doing it endoscopically, laparoscopically, or via vNOTES. And I think whichever technique gives you the most confidence to do it safely for your patient is the one that you should choose. So I think there'll be a place for it in time for sure. With development of more and more new robotic systems, it will come. But I think at the moment, it's for a specific niche.